It's a LASIK, it's a femto-LASIK, it's a smile, it's a surface ablation, it's a ICL, or maybe we can include the refractive lens exchange. The answer is none. Because you cannot say one shoe will fit everyone. So there are choices you have to make, depends on the patient. So I'm going to speak on recent trend, that's in refractive surgery, back to surface. So from lamellar, we are coming back again to surface. This was the history, I'll not go in detail, but PRK was started in 1988, FD approval came in 95, then LASIK in 90, and the femto flap in 2001, Smile and Contura got FD approval in 2016. This is again a little bit of surgery, I think most of the person on faculty here, they know it. Then came the PRK was the first laser surgery after RK. It was more accurate, it can correct myopia, hypermetropia and astigmatism. The results are pretty stable as compared to RK. But the problem was, it was having a lot of pain, there was a delayed healing, there was a scarring of the cornea. Then came LASIK. There was a rapid recovery, there was a wow factor, patient had 6/6 vision after a few hours, there was decreased risk of scarring, no pain. But the problem was flap-related complications like scar, buttonholing, partial flaps. Then again on the interface there may be debris, epithelial growth, there may be DLK, late trauma can displace it, and ectasia was a real threat. Then came the femto flaps. These are flaps or thinner flaps, fewer incomplete flaps or buttonholing, but still we had problems like persistent photophobia, higher DLK, late trauma can still displace it. Ectasia is again a problem in these cases. Then came the smile. After there was no flap, there was still we had some problem with the, it's not a flap, but then we have lenticle related problems, which was explained by Dr. Shri also. At present, it can't correct myopia. I think Dr. Shri is working on it, and maybe by tissue addition, it will work, but at present it's not there. Then customized treatment is not possible in smile at present, difficult in low power correction, bitoric execution difficult, treatment centered on the pupil, no cytotoxin compression, or you can do it manually. You can mark and do it manually. It's a manual, then manual centric, manual cytotoxin. I think things are improving, but I think still some limitations are there. If we have a little decentration in femto-LASIK, it's not going to affect, but a smile, there is a high comorbidation. That's not uncommon. We came back to surface again. There were procedures like LASIK, epi-LASIK, now that has been abandoned. And advanced surface ablation, what we call is a new avatar of PRK, it's getting popular. There are some specific indications like irregular astigmatism, FFKC, thin cornea, night vision concerns, anterior stobal opacity can be corrected with this. Contact sports hazardous beauty, prior RK, AK of LASIK. Then if you want to do customized treatment, it's a good choice. In the patient, we were just discussing RD surgery, filtering blanks, deep set lines where it's difficult to put macrotome. It can be done, or even PI also. It can be combined with C3R also. These are the preoperative evolution, just like any basic procedure. Vision, manifest encyclopedic refraction, pachymetry, topography, and agglometry. Then the procedure is very simple, just put a few local drops. Epithelium removal has not changed a lot. It was a manual removal, then came the Avoidance flush technique, then laser escape, then alcohol assisted, and epibomus keratotomy. This is a Avoidance flush, then alcohol is almost not being used nowadays. So epithelium is removed, laser is applied, and that's all. Mitomycin was a game changer. It has decreased all the scarring, haze and everything has decreased a lot, and we are getting much clear corneas. Of course, mitomycin is toxic, but using it, we have safely used it in eyes. It's working very well. Most of the complications like haze, delayed healing, scarring has gone. And new drugs are being developed which are much safer than mitomycin, like Saha. But it still is in trial. Dr. Rohit is working, others are also working on it. Let us see how the results come. Then bandage contact lens is applied and usual antibiotic and lubricating drops are used. The complication with surface ablation were stromal scarring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial erosion which may cause significant discomfort, and epitheliopathy. So we could understand here the epithelium is the most important part. We have to take care of that. If the healing is good, then everything is going to be good. So how to improve your results in surface ablation? There has to be careful preoperative checkup. We have to look at the lid. If there is a blepharitis, we have to put lid hygiene. We have to use scrubs and antibiotics. Dry eye artificial tears, cyclosporin drops, ointment of puncture plugs. Dry eye is very common in middle-aged person, and especially the younger person now it's getting common. So we have to take care. Before the procedure, I use prednisolone just once a day for 2 days. But some people are using up to 6 days. It reduces a lot of pain. In the operative procedure, MMC have just talked, it prevents haze, and the contact lens should be of very good quality. It should be a proper fitting contact lens. If you see any debris or anything under contact lens on second, third day, just remove it, change it, because it's going to make a lot of difference. Then Dr. Rohit Shetty has gave the idea of actival contact lens soaked in actival. It reduces the pain definitely, no doubt it. I am using it. Then newer contact lenses are coming which can dissolve on the cornea, will not be needing bandage contact lenses, but they are still in the pipeline. NS should be avoided, and once the epithelium is over we can use it, but should not be used more than 4 to 5 days. Post-operatively, avoid over-use of topical anesthesia. It's not being used now, but earlier because of the pain, some patients were using and doctors were giving also, but that's a bad thing. Oral steroids helps. Then oral pain agents are now better pain agents. Avoid amino glycosides. These patients, these are epitheliotoxics. And to improve epithelial regeneration, we have tried so many things. Doxycycline may be used for persistent epithelial defect. UV exposure has to be avoided. Give them a good quality UV blocking glasses. Normally what happens, they go to market if they buy any glass. But you have to check it yourself whether it's a 100% UV blocker or not. You can have a UV light with yourself. There are a lot of lights available and you can check whether it's blocking or not. I did in every case. I am also doing it. Because in market there are a lot of duplicate glasses, so-called branded. They are having a good brand, you say branded glasses got good, but still you can get duplicate glasses also. Those things, you have to check it very, very carefully, because this is a single factor which you don't take care and patient come with the haze. Then nutritional supplement have been tried. What changed now? Why it's come back again? It's the epithelium which we were removing by many ways, which was not perfect. So Schwinn and Alpha have come with a different technology where epithelium removal has become very smooth. It has become basically a optimized sort of thing where the removal is uniform throughout. There's some epithelium left on the cornea in between. So this is from a streamline. The correction now we can correct up to 10 diopter. So think from 3 to 4 we have just done to 10 diopter. It's giving good results. I have done around -8. I think Dr. Gaur is working with me also. He has done a high number also, good number. Then myopic astigmatism, hyperopia, hyperopic astigmatism, mixed astigmatism, all can be treated very well. And it's a single step procedure. There's a single centering. You don't have to do centering for PTK. Then you have to do centering for laser. These things are combined in one procedure, so that makes the things very, very accurate. So it's a one step. There is no time lag. First, epithelium removed, followed by refraction correction done. Optical zone selection and corresponds to refractive correction. Less myopic shift compared to standard PTK what we were getting earlier, and we were adjusting our nomograms. Now, uniform removal is the key. It's more predictable, refractive outcomes. So, steam light utilizes, because I'm using it, steam light utilizes optimized epithelial vibration profile. More pulses are used outside 4 mm zone to prevent epithelial remnants. Steam light is one-step treatment requiring only one centering, therefore enhancing precision. There is active timer throughout the entire process. Epi-ablation dose automatically determined by the software, so you don't have to ablate extra. Suppose it's a 6 mm your zone, it will go up to 6.5 mm. There is active tracking throughout. So the advantage of transepithelium PRK over PRK is it's accelerated healing with visual recovery, while limiting minimum epithelium removal. There is less pain because the cells are not being damaged. Reduced risk of haze because of accelerated healing. There is a smooth surface and better contour by removing damaged cells and reducing the thermal effect. The shortcomings of this new technique is that it accentuates the importance of epithelial mapping from proper surgical planning. If you want to have very good results, you have to map the epithelium and plan accordingly. So naturally you have to buy newer devices. And it's still, we can't do the customized treatment in this modality. What we can do in normal PRK, we are not able to do this for the like custom Q or Contura. And it has a price tag, we have to pay per click fee in these cases. So just to summarize, advantages of surface ablation is it's very gentle. No touch, no cut, no cap, no incision. Safe, more biomechanical preservation, corneal stability is there. Stress-free, faster treatment in a single step. We are not passing the cornea anywhere, not indenting anywhere. So no effect on the posterior segment. Excellent clinical outcomes can be combined with CXL, and it's quite economical compared to femto laser or smile if you think of. So it's a very useful tool in our surgical armamentarium. So it can be effectively used, and my take home is it's underutilized, but it's a very promising and exciting with superior results. Thank you.
Thank you, sir. I would now like to invite Dr. Anand and Dr. Kakkar to please honor sir with a memento. Meanwhile, do we have any questions or comments?